All right, as we move along quickly now, Rick Fort, PhD, is Cerescan. Remember we saw this actual scale model of my own brain right here. They provided. Cerescan, of course, he's the Chief Science Officer as well as a member of the Board of Directors. Dr. Fort began his career, interestingly enough, in the Space Shuttle program at the Kennedy Space Center, where he worked organizational development with a focus on leadership, employee motivation, total quality management. Dr. Fort has earned his BA and in psychology from Louisiana State University, his MS in experimental psychology, Northeastern Louisiana University, and his PhD in psychology at Walden University. As Chief Science Officer for Cerescan, Dr. Fort uses his applied research skills to focus on innovative treatments for various brain disorders with an emphasis on traumatic brain injury, of course. So Dr. Fort will be presenting some of the latest research now into TBI diagnostics and therapy. Let's welcome Dr. Rick Fort, please.
Thank you. It's not lost on me at all that I am one of the last people standing between all of you, all of us, and cocktails. It's also not lost on me that you've all been sitting for pretty much all day and certainly the last hour. So if you are able, I'm going to ask you to just stand up for a second. Just stand up, turn around, say hi to your neighbor, stretch a little bit. Yeah, wiggle around a little bit. We're in the home stretch. All right. Yeah, massage is good. Wayne, can we get this, for maybe next year? So, I have to tell you that I have an invisible disability. It is temporary. And it is my shoulder. So I've been having some shoulder problems, some range of motion problems for, about a year or two. If my wife were here, she would say it's been going on for 4 or 5 years. I keep telling her we need a new mattress. She says, it's not the mattress, it's your shoulder. Go see your doctor. I did. So my doctor did a little bit of testing, and he said, of course, well, go get an MRI. So this is my MRI. And any radiologists in the room? So what this shows is a little bit of rotator cuff, deterioration, no tears. It's got a biceps tendon problem, and it's been causing pain, and that is really what the diagnosis was. Sat down with the radiologist. What do you think the radiologist recommended I should do? Surgery. I didn't really want to end up like this guy. I've had friends, I've had family members get the rotator cuff surgery. It's not fun, it's painful, and it takes 6 to 12 months to recover from. So I went back to my doc, and he said, well, why don't you try stem cell therapy? So stem cell therapy was done at the Premier Stem Cell Institute in Loveland, and this was just a week and a half ago. What they did was they extracted stem cells from bone marrow out of my hip and re-injected that into my shoulder. And it's actually starting to feel better. It takes about 3 to 6 months for the stem cells to start making new connective tissue. But I didn't want to end up doing this. Proper diagnosis led to a really good treatment solution, I think. I'll be able to report more in about 6 months, but so far, so good. Diagnosis, though, is one of the problems that is starting to gain more awareness in the country. The National Academy of Sciences is one of the premier institutes in the U.S. It was formed by an act of Congress. It was signed into law by the president, this president, and it's been around for over 150 years, and it is populated with members of top-tier universities around the country. And the purpose of the academy is to advise the nation on matters of science and technology and medicine, and help us all understand what the state of art is. They recently came out with a report called Improving Diagnosis in Healthcare. When I say recently, this was just last month that they came out with this report. They had been working on this study for the past couple of years. Some of the highlights of the study indicate that in a conservative estimate, 5% of us seeking outpatient care will experience a diagnostic error. Now you think about 5%, well that doesn't seem like a very large number. That number is actually 12 million people. So if you think about if you were one of those 12 million, post-mortem research shows that diagnostic errors contribute to approximately 10% of patient deaths. This is all in this report. Diagnostic errors are the leading type of paid medical malpractice claims. The best estimates indicate that every one of us will experience a meaningful diagnostic error in our lifetime. Now, we've had some speakers today talk about some of the diagnoses that they went through over and over and over, hopefully finding the one that was correct. We find this at Cerescan in our own research. What we have looked at is brain-related misdiagnosis rates. TBI is misdiagnosed up to 33% of the time. Now, Jim was just talking about PTSD. The symptoms between PTSD and TBI overlap tremendously. So when you're presenting clinically, you may not really know what the problem actually is. It looks a lot alike in the clinic, but they're actually very different disorders. ADHD is overdiagnosed, 20% in high school boys. Boys just tend to wiggle. They tend to be active. They tend to be overactive sometimes, and it gets diagnosed. The resulting overmedication of boys in particular is one of the problems that goes with this. Bipolar disorder, up to 69% of the time. If a person is presenting in the clinic as depressed, oftentimes they are diagnosed with depression, when in fact, they may have bipolar and they're simply on the depression side of that syndrome. Parkinson's is misdiagnosed up to 25% of the time. Today, the technology is such that we can give an up or down diagnosis of Parkinson's using SPECT imaging. Alzheimer's is misdiagnosed up to 30% of the time. Frontotemporal dementia is not the same as Alzheimer's, and we heard about Alzheimer's earlier today. These are two different types of dementia. We can differentiate that at Cerescan. But this report was about improving diagnosis. It didn't just get stuck in all the problems and all the misdiagnosis rates. It talked about how to go about trying to do that. Improving the diagnostic process is not only possible, it represents a moral imperative. And it's something that the National Academy of Sciences is pushing more and more today. There are several recommendations in this report to improve the utility of health information technology, data, and the diagnostic process. Health IT, the data that goes with assessments, has the potential to improve diagnosis and reduce these errors by facilitating timely and easy access to information. The mission at Cerescan, the reason that we exist, is to provide the most advanced, comprehensive brain data analytics for the purpose of improving diagnoses, patient outcomes, and science. The struggle that we run into is this type of thing. When medical doctors think about SPECT imaging, they're thinking about the way it used to be. We call this the blob. That's what it is. You can't diagnose much by looking at this. But this is what medical professionals, what doctors think about when they think about SPECT imaging today if they are not up on what's going on. There is a saying that we have at Cerescan, and you've heard this before, doctors tend to be down on the things that they're not up on. This is what our images look like. Now, I will tell you that this is my brain. It's always a little bit precarious when I drag my brain out in public like this. One of the speakers earlier said that we need to know our brains. Well, I know my brain. This was a scan from a couple of years ago. And the first thing to note about this image is that when you look at the color scale, gray is good. Gray is within the normal range of this color palette. Green is 2 standard deviations below normal in terms of cerebral blood flow in that particular region. Blue is 3 standard deviations. Dark blue would be 4. Black would be 5. Red is actually 2 standard deviations above normal in terms of blood flow in that particular region. So what we're looking for are patterns of blood flow in a patient's brain. Now what you'll see here are the brain sits inside of the skull and it has bony ridges. When I was a kid, I was always hitting my head. I had my head stitched up a couple of times. I was in accidents. I was a fairly typical boy doing boy things, and most boys growing up, most of the men in this room have probably bumped their head or knocked their head several times. Everything that we do, though, is about data. We generate nice pictures, but it's based on data. No one's sitting there coloring the color palette. This is being produced by data. We look at normative data. When we take a patient's images, the data that we get from that goes through our software and it's compared to normative databases. We collect for every scan that we do 262,000 data points. It's a 64 by 64 by 64 matrix of voxels in 3D space, and it's all compared to normative data. What we're doing is advanced neuroimaging and neuroanalytics. So what we do is called QSPECT, quantitative single photon emission computed tomography. We also do PET-CT imaging. This is nuclear medicine using radioisotopes. Now let me shift gears for a minute and tell you about a study. We know that the veterans that have served our country have gone through quite a bit. And some of the data that has come out recently is kind of astonishing. Military suicides are at their highest rate. More military deaths by suicide than in combat in 2012. Over 300,000 TBIs in the last 15 years among veterans. The VA has put out data that says that there are 22 suicides per day among veterans in this country. Think about that. 22 per day among veterans in this country. We wanted to do a study, and part of the reason that we wanted to do a study is that we're looking for things that can help fix TBI, can help reverse the brain damage that we see here. So we did a study. And this study was done, we call it the Invisible Brain Injury Project. It was funded by the Tug McGraw Foundation. We partnered with Colorado Neurological Institute, who provided oversight in this study. They're a great partner. They are a great community resource here in Denver and in Colorado. Do many, many research projects. It's a small study. We only had 12 veterans in the study. TBI, 6 weeks of treatment, 3 times a week, Monday, Wednesday, Friday usually, and 20 minutes a session. When you do the math on that, that is a total of 6 hours of treatment. We wanted to look at the impact of this treatment on TBI symptoms, cognitive performance using neuropsych tests, and blood flow using QSPECT. Again, I want you to think about this is my brain. This is one of the soldiers that we worked with, one of the patients. Again, think about gray is good. Dark blue is 4 standard deviations below normal. Black is 5 standard deviations. When you talk to this patient, it was difficult for him to look you in the eye. He had feelings of rage. He looked like if you said the wrong thing, he might explode all over you. He was depressed. He had all kinds of the normal symptoms that we think about with TBI. This was the treatment. This is polychromatic light therapy. Polychromatic because we're using 2 wavelengths of light here, red light and near infrared. Now this looks a little bit kludgy. Again, this is a pilot study. So we put together some pads and some devices, and the near infrared and the red lights are transcranial, and they bathe the brain in the light. And what's happening here is we are stimulating the production of a molecule called nitric oxide. Now, nitric oxide is in our bodies. It's in the food that we eat. It's in the medications that we take. It's in aspirin. It's in morphine. It's in that little blue pill that some men take for ED. Nitric oxide is a vasodilator. It opens up the blood vessels. And that's what's happening in the brain. It is opening up damaged blood vessels in order to generate blood flow through the brain. Neurons eat glucose, and they need oxygen to be able to metabolize that glucose. The only thing that gets it there is blood. You've got to have blood flow going in the brain. That's what this is doing. What happened? These were the symptoms. We had everyone do a symptoms checklist. The blue was pre-treatment. So you look at some of these things. The first set are all physical kinds of symptoms, headache, dizziness, sleep problems, etc. The middle ones are really more psychological, depression, irritability, things like that. And then the last group are really cognitive problems. Everything went down. Symptoms went down. I'm reminding you that this is 6 weeks of treatment, a total of 6 hours of exposure to the polychromatic light therapy. The only one that didn't really register was nausea, but it seemed to be a problem, at least among these 12 in the first place. But all of these symptoms went down. Now, these are self-reported symptoms. You might say, well, there's placebo and you can fake that sort of thing. We also looked at neuropsychological test performance, basically looking at subscales of the Wechsler Adult Intelligence Scale, which is one of the IQ tests used today. And what we saw is an improvement across the board in cognitive performance. Auditory learning, the memory subscales, cognitive processing speed, all of these got better from pre-treatment to post-treatment. So what happened to our one patient's brain? So as I mentioned, this particular one, and this is kind of typical of what we saw in this study, was pretty messed up. This is a lot of low blood flow in the brain. So after 6 weeks of treatment, this is what his brain looked like. It's a remarkable difference. And the only way that you can get to this sort of thing is by looking at SPECT and actually measuring this and taking a look at blood flow in the brain. One of the divisions that we have inside of Cerescan is Cerelab, and what we're interested in is more research along these lines. So for example, this is a gyrostim. And what gyrostim is doing here is basically stimulating the vestibular aspects of the brain. And the marketing on this particular device, by the way, the inventor lives in Colorado Springs. It's manufactured here in the state, but it's sold around the world. It is stimulating the vestibular aspects, and it's for balance. Right now, the claim is around balance training. But he believes that this is a therapy for traumatic brain injury as well. We don't know. He's had some anecdotal evidence of that. This is hyperbaric oxygen therapy tank. There is evidence that HBOT is doing tremendous things for TBI. There's certain studies that show that it's very effective, and there's some that, in particular, the military doesn't seem to think that it works on military people, but seems to work on civilians. I don't quite get that, but this is a therapy that we're very interested in. This is CVAC, cyclical variations in adaptive conditioning. Essentially, you get into this chamber, closes down, there's a plexiglass thing so you can see out, and it takes you through pressure profiles between sea level and about 22,000 feet, up and down. Not the whole way. You might go up to 5,000, back down to 2, up to 7, back down to 4. Up and down, up and down. It is for extreme athletes, for conditioning, but they also have found some evidence that this could be a treatment for traumatic brain injury. We don't know. Neurofeedback is a very popular therapy today for a variety of brain disorders. We are talking with Denver Sports Recovery. We had one of the board-certified neurofeedback therapists from Denver Sports Recovery here today. But this patient is moving things using brain waves in that video game. Is this a treatment for traumatic brain injury? Possibly. We don't know. It doesn't have to be like this. It doesn't have to be 22 suicides a day. There actually, I think, is a lot of hope for where we're going, what Cerescan is trying to do. We want to find out what works, what doesn't work, and we want to pursue those things. Thank you.